Hello, everyone, and welcome to today's webinar, Procalcitonin's B-cubed effect, from bench to bed to patient benefits. I'm Christina Jewell of LabRoots, and I'm your host for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more about our sponsor, please visit thermofisher.com. Now, we encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. Also, if you experience any technical questions, you can utilize this Q&A box and we will assist you directly. I would now like to welcome Professor Hannsjörg Baum, and he will be your moderator for today. Professor Baum is the medical director at the Institute of Laboratory Medicine and Transfusion Medicine at RKH in Ludwigsburg, Germany. He is a distinguished specialist in laboratory medicine and clinical chemistry. Professor Baum is a foundation fellow of the European Board of Medical Biopathology, U.E.M.S, and European Specialist in Laboratory Medicine, EFLM. He is actively involved in quality assurance programs and research, particularly focusing on the performance evaluation of laboratory systems and methodologies. Professor Baum, welcome. You may now begin.
Dear Christy, thank you very much for your kind introduction. Now it's to me to welcome you all to the webinar entitled Procalcitonin's B3 Effects. I will guide you through this webinar as a moderator. Before I introduce the first speaker, I will show some order numbers of procalcitonin in the hospitals I'm responsible for. As you can see, during the last 6 years, the orders of procalcitonin were increased in each hospital if it's large on the left side, the button, or to the right side, from 19 to 24. But are all those orders really necessary? Where's the benefit for the patients? In my opinion, there are surely a lot of unnecessary orders among them. But our two speakers will deliver insight into the use of PCT, in which situation it is helpful tool in diagnosis, therapy decision, and follow-up of patients, as well as managing antimicrobial resistance and antibiotic stewardship. So the first speaker I have to introduce to you is Professor Gruson. He's the head of the Department of Laboratory Medicine of the Clinique Universitaire Saint-Luc in Brussels, Belgium. He's a member of the research unit of endocrinology, diabetes, and nutrition at the Catholic University of Louvain. He is a member of the EFLM task force on green labs. He is also the chair of the executive committee of the Division of Emerging Technology of the IFCC, board member of the Belgian Thyroid Club, and a fellow of the European Society of Cardiology. The title of his presentation is Breaking Barriers with BBB, PCT from Value to Budget Impact. Unfortunately, due to technical problems, the presentation of Professor Gruson is recorded. Let's start.
Hello, good morning everyone. Really happy to be part of this webinar and be able to discuss the aspects around procalcitonin testing. I'm really grateful for the organizers, for the kind invitation, so thanks a lot. And my name is Professor Damien Gruson. I am practicing at Clinique Universitaire Saint-Luc in Brussels, Belgium. We are a tertiary care hospital located not too far from city centers, and if you are visiting Brussels, let me know. I will be happy to show you the hospital, the campus, and advise you for some good stuff to see in Brussels. We are in a global context where there is a need to manage antimicrobial resistance across healthcare system. There is a burden, and we have to find solution and use innovations to help in this fight. And at least there is perspective coming from new generation of antibiotics, not easy, but perspectives coming, and from innovation in the field of diagnostics, from the biomarker and emerging biomarkers to emerging technology in testing, from point-of-care devices to sensors. First, let's start by what is procalcitonin. Maybe you are already familiar with PCT. PCT is the precursor of the calcitonin hormone produced by the thyroid gland and used mostly as a cancer biomarker. The precursor is cleaved to the mature CT, but there is a processing with different steps of maturation, different precursors that can raise, and it's important to already understand this processing, which can influence the specificity of the assays. We have access to kind of assays including the calcitonin testing and the procalcitonin testing, and we have automated assays for both. Procalcitonin under the basal condition is responding to calcium concentration at the level of endocrine cells. There is also the capacity to stimulate calcitonin level based on a calcium loading test, and there is other stimuli like inflammatory mediators, interleukins, TNF, that will trigger the rise of PCT during bacterial infections. We have therefore a biomarker more specific to bacterial infection, unlike some other markers. The kinetic of increase of PCT begin to rise within 2-4 hours and having a peak at 6-12 hours, and then will decrease if the treatment is efficient. The previous presentation highlight the clinical value of procalcitonin in the infection management, early sepsis detection, antibiotic stewardship, and a reduction of antibiotic usage. If we look now to the operational value of PCT, it's clear that with the progress of automated PCT testing, we have efficiency in large-scale testing. Central labs benefit from the automation, so we can deliver PCT results in a high throughput and with a rapid turnaround time of analysis. The process has streamlined, and we have capacities to deliver the results in about 1 hour or at least less than 2 hours. We have this cost effectiveness of automated testing with lower labor cost, improvement of the resource allocation, and when needed, the capacity to handle a large volume of samples. We have different kind of PCT automated assays accessible on the market. There is the one derived from the original BRAMS PCT test and adapted in different platforms from different manufacturers, and you have the non-BRAMS PCT assays that can be also plugged on different manufacturer platform. There is overall good correlation between the BRAMS PCT derived assay, a good precision, as mentioned in the summary points from the ADLM guidance document, and the non-BRAMS have less correlation with the original crypto-BRAMS assays. So, but different perspective, different possibility to automate your PCT assays. We have also new promises coming from the field of point of care testing, with benefit in terms of immediate results at the bedside, with a more rapid decision making and a reduction of uncertainty at the time of diagnosis for the physician. We can broaden the use of PCT, improve the accessibility with more decentralized testing, and potential role for broader implementation, expanding the primary care setting as a field of implementation, with help for the GPs to differentiate bacterial from viral infection, in addition to other tests like the CRP, for example. If we look now in the cost effectiveness of PCT testing, we have different studies reporting the added value in terms of budget impact and beneficial budget impact around the world. Here with the team in Brussels, we were able to run a study to estimate the impact of PCT guided antibiotic stewardship compared to standard care in patients suspected of sepsis and admitted to intensive care unit in Belgium. In terms of methodology, the study design was study conduct as a budget impact analysis to compare PCT guided antibiotic stewardship in front of the standard of care procedure. We used a decision analytic model incorporating data from literature reviews, expert surveys, and national database to estimate the cost and health outcomes. The key parameters included were the antibiotic therapy duration, the incidence of antimicrobial resistance, and the length of stay in the intensive care unit. The main results of the study was clearly a reduction in the number of antibiotic days. PCT guided antibiotic stewardship results in a reduction of more than 66,000 antibiotic days per year, translating into a significant cost saving on antibiotic treatment, around 1.8 million per year. The other important point was the impact on the antimicrobial resistance. with the implementation of PCT testing that can result in a reduction of AMR by 7.7%, potentially avoiding 256 cases of AMR infections annually. In terms of other important results, we have to mention the reduction of the length of stay in the ICU of about 1.46 days, reduction of mechanical ventilation, and more generally an overall savings where the scenario including the PCT could have an impact in terms of savings of more than 49 million euros per year. So significant results, and you can see on this first tornado diagram that the key drivers of the budget impact of PCT-guided antibiotic stewardship show the reduction of antibiotic therapy duration as the most important factor influencing the cost saving. And on this other tornado plot, you can see that the reduction of intensive care length of stay due to PCT testing lead to a substantial cost saving, making it as the primary factor in the overall budget reduction. So the take-home messages for these budget impact studies are clear clinical and economical benefits, economic advantage in terms of savings, clinical benefits in terms of reduction of exposure and to antibiotic and decrease of AMR. The investment is about 1.9 euros per patient, but the impact is million euros per year, and the scenario was robust based on the various assumption and data available, so triggering more evidence for the reimbursement of PCT in Belgium. PCT testing is not without challenges. There is still a need to move forward for standardization of assays. Inter-method variability still exists, and the different kind of assays, formats, different length of incubation, signals, antibody use lead to variability between methods. So we need to standardize and encourage harmonization through scientific societies, and you can see on the results of this study that even if the method were not standardized and the bias were consistent between assays, the clinical concordance was overall excellent. So we can anticipate also improvement of the clinical concordance with better harmonization for sure. We have study reporting the bias for the different assays in the literature. We have also nice data showing the results of external quality control. Fortunately, now we have access to external quality control, allowing clinical labs to monitor the performances, but also evidencing the bias and inter-laboratory variability. Not all EQA chains are equal, and we need more commutable materials also within the EQA. We still have the need also to be more personalized in terms of reference values. There is reference value that must be adjusted, especially in neonatology and early years of life, where there is an important increase in PCT concentration, and clinical laboratorians should inform the physician about potential confounding factors that can elevate PCT concentration outside of a bacterial infection, like trauma, surgery, or renal dysfunction. Different challenges, but we have also great perspectives to maybe overcome these challenges. Emerging technologies are coming. The push for standardization from scientific societies is already there. So in terms of emerging technology, we can mention point-of-care testing for PCT, sensors with perspective for primary care, remote monitoring. The combination of data and electronic health records with biomarkers can power the diagnosis confidence. AI, of course, with support for the clinical decision, but also improvement in the assay design. And at the end of the day, we will go for better precision in care, more personalized care, and more standardization in assay design and performances. So I would like to take the opportunity of the webinar to invite you to EuroMedLab 2025 in Brussels from May 18 to 22nd, and I would like to finally thank you for your attention, and thanks again the organizer for the opportunity and for kindly inviting me.
Okay, Damien, thank you very much for your presentation, including the view from the laboratory perspective. That's something good for me. I hope you can hear us now, but before we can answer any questions, we will hear the second speaker. It's Professor Evangelos Giamarellos-Bourboulis. Professor Giamarellos is a prominent expert in infectious diseases in immunology. He has published over 500 scientific papers, contributing significantly to the fields of sepsis and infection management. As a professor at the Medical School of the National and Kapodistrian University of Athens, he heads the master's degree in clinical microbiology and infectious diseases, playing a key role in educating future healthcare professionals. Professor Giamarellos also serves as the president of the European Sepsis Alliance, where he leads efforts to improve sepsis awareness, diagnosis, and treatment across Europe. His work has been instrumental in shaping clinical guidelines and advancing sepsis research and care. The title of his presentation is The Bench-to-Bed Paradigm, How Laboratories Empower Clinicians to Antibiotic Stewardships. Professor Giamarellos, please, it's yours.
Well, thank you very much. And honestly speaking, after all these extremely kind words which you said for me, I hope that I will manage to convince our audience that I'm deserving such an honor. Thank you very much for your kind words. Before moving forward, I would like to share with you my disclosure of interest for this presentation. And I would like to ask you that all together we try to elaborate and make this presentation much more interactive. With this in mind, during the presentation, you will come across some questions. These are multiple choice questions. You will be given several choices, several options to answer, and I would very much like to welcome you that you answer this, and then I will try to elaborate and comment what, in my opinion, the correct answer may be. So the first case is a male of 70 who's admitted for cough starting 48 hours ago. He has a positive medical history for chronic obstructive pulmonary disease. Physical examination is unremarkable and laboratory results are known. You are being given the chest X-ray of this patient, and also you are being given 4 options. The question is, what will you do for this patient? The first is discharge him home. The second option is watchful waiting. The third is empirical clarithromycin for 7 days. And the fourth is any of the above. So I would like to welcome you to think a lot about that and frame your option: discharge home, watchful waiting, empirical clarithromycin for 7 days, or any of the above. Allow me to get your results of that. Please vote. Discharge home, watchful waiting, empirical clarithromycin for 7 days, any of the above. At least in the poll I have in front of me, I see that some of you have already started voting, and I see that the majority of you are between watchful waiting and empirical antibiotics for 7 days. Now let's see what is the rationale behind that. There is a silent disaster for the patient. And the silent disaster is how we elaborate resistance. In other terms, how gut flora becomes resistant. Imagine that what you see is the mucosa. Each of the bricks that you see in blue is one epithelial cell of our gut, and what you see in red or top is the normal gut flora. The patient is treated with an antibiotic, irrespective if the choice of giving the antibiotics is correct or wrong. The antibiotic will kill all bacteria, but because they are billions there, some of them will survive. They survive because they are inherently resistant. And these bacteria, they realize that there is an ecologic gap. They start rapidly to multiply in order to cover the gap. And all of a sudden, this susceptible to antibiotics flora has been replaced by a resistant one. So in other terms, if we want to give empirical antibiotic to our patient, we need to be certain that the patient is in need of an antibiotic. However, what I presented to you as a hypothesis, the real question behind that is whether this is supported or not by clinical evidence. In other terms, we are in need of a randomized controlled trial which takes place in healthy volunteers. Indeed, such a trial took place. The coordinator of the trial is coming from Brussels, and the trial was not funded by the industry, it was funded by the European Union, and healthy volunteers were randomized to get a complete oral course of clarithromycin, or a complete oral course of azithromycin, or they received matched placebo, and then the volunteers were followed up on the incidence of resistance in the gut flora. And look what happens. Day 8, end of treatment, there is resistance, no doubt about that. However, before commenting on what is surprising, which is the development of resistance, allow me first to comment in the bar of the placebo. You see that even the placebo treatment induces small resistance. That means that by definition, in our daily life, there are bacteria in the gut flora which are inherently resistant. On day 8 after giving antibiotics, this resistance rate is exploded, but it is even there on day 14. On day 28 after end of treatment, 42 days later, and even in some patients, it persists after 6 entire months. Now, let's change a bit our approach. Use biomarkers to guide antibiotics treatment. In terms of surveillance of antibiotics, and what we need is to incorporate procalcitonin in an algorithm, which can tell us the need to start antibiotics, the time to stop antibiotics, adapt antibiotics to underlying severity, setting, comorbidities. In other terms, the main requirements is not to introduce harm with that approach, to provide clinical efficacy, and in other terms, to validate this algorithm through randomized controlled trials. Allow me to provide you some recent knowledge which was published 1 year ago at Lancet Respiratory Medicine. These are patients with community-acquired pneumonia, and all included patients. They have procalcitonin less than 0.25, and they are randomized to 5-day treatments with placebo or azithromycin. The primary endpoint is a composite point of non-inferiority, taking into consideration not only the improvement of the patient, but taking into consideration the harm introduced to the patient and the adverse events. And the investigators, in order to better elaborate on that, they introduce a score with the acronym DOOR, and you see that as a matter of fact, there is no inferiority between placebo and azithromycin. In other terms, when procalcitonin is less than 0.25, the investigators, what they tell us is that if you see that the patient is stable, procalcitonin is low, probably, and pneumonia is mild, probably it's better not to give antibiotics. And this knowledge has been tested through algorithms also in the past. And you see here in this table the cumulative knowledge of 3 randomized controlled trials conducted before 2010. And actually, in these trials, the first is taking place in patients with CAP, the other 2 in patients with acute exacerbation of chronic obstructive pulmonary disorders. Patients are randomized to treatment as usual, in other terms, to receive antibiotics by the experience or the discretion of the attending physician, and the other arm where antibiotics are guided by procalcitonin less than 0.25. In all 3 randomized controlled trials, consumption of antibiotics went down, and there were no differences in mortality. Now allow me to ask your feedback for a second case. A male of 62 who's admitted for mental confusion. Physical examination reveals 27 breaths per minute. Systolic blood pressure is 95 millimeter mercury, and there are diffuse rales on auscultation. Abnormal lab tests are partial oxygen pressure 43 millimeter mercury in the air, urea 65 milligrams per deciliter, C-reactive protein 107 milligrams per liter, and procalcitonin 15.2 nanograms per ml, and also you see the chest X-ray. Now the questions are, what will you do for this patient? Discharge home, watchful waiting, empirical clarithromycin for 7 days, any of the above? Or some of you even consider that some of these approaches is far too much, and this is a severe patient who requires treatment. I'm really curious to see in that really challenging approach regarding the options which we have delivered to you, what will be your feedback. So discharge home, watchful waiting, empirical antibiotics for 7 days, any of the above, and allow me to ask your vote for this. Please vote. So what I see so far from the votes which are coming is that the majority, more than 80%, believe that this is the profile of a patient who requires antibiotic treatment. Let's see what happened to the patient. This patient, as we said already, is probably close to become critically ill. He suffers from severe pneumonia, and the patient has a result of Streptococcus pneumoniae in film RA. He starts on intravenous ceftriaxone, and after 72 hours, he becomes fully conscious. Systolic blood pressure is restored to 125 millimeters mercury. Urea goes down to 38 milligrams per deciliter. And after 120 hours, procalcitonin is 1.35. I remind you that baseline procalcitonin of this patient was 15.3. And now I want your feedback. How will you react, taking into consideration the improvement of the patient and the improvement of the biomarkers? And now I give you the following option: discharge home, stop antibiotics, continue treatment for a total of 7 days, or the last option, continue treatment for a total of 10 days. So I kindly ask you to take into consideration the rapid improvement of the patient, the change of the kinetics of procalcitonin, and I gave you 4 options: discharge home, stop antibiotics, continue treatment for a total of 7 days, or continue treatment for a total of 10 days. Allow me to have your voting on that. Discharge home, stop antibiotics, continue treatment for a total of 7 days, or continue treatment for a total of 10 days. So what I see is that the majority, more than 50%, you believe that based on this change of the kinetics of procalcitonin, you need to stop antibiotics. However, equal to that, as a matter of fact, the line separating those who selected the second option, stop antibiotics, to those suggesting continued treatment for a total of 7 days, both these are really close. And as a matter of fact, what I see is that the more votes we receive, the more they suggest continued treatment for a total of 7 days. So now let's comment. Here is the eternal problem. When a patient is doing bad, the answer is easy. We change antibiotics and we up-escalate. But if he's doing better, then all of a sudden is, may I stop antibiotics? And how about if he gets undertreated? How about if he relapses? In other terms, we need a biomarker, which is the readout of the reaction of the host to treatment, and which can tell us that substantial improvement has been already done, and there is no need to continue treatment. In other terms, we are in need of a stopping rule. And a stopping rule using procalcitonin means that once we decide to treat pneumonia, we need to get one procalcitonin measurement before start of treatment. And then, once the patient is on antibiotics, to repeat treatment, and starting measurement of procalcitonin again after the first 120 hours, we need to consider whether we will stop or not. There are 8 randomized controlled trials which has been done so far. They studied the impact of different rules. As a matter of fact, the idea is that the rules, they require an at least 80% decrease of procalcitonin from baseline. But then someone may ask, okay, the example which we already have was the example of a patient who had a really high procalcitonin at baseline, 15. So 80 or 90% decrease goes down to 1, exactly as happened with our patient. But what can be the case if our patient starts with a procalcitonin of 0.5? Then the answer is that if after 5 days procalcitonin stays below 0.25, then stop treatment. So this is a cumulative picture of 7 of the 8 randomized controlled trials. In all of them, the follow of the stopping rule decreased the time of antibiotics without putting any life at risk. But someone may argue, in order to be certain, we would like to see a randomized controlled trial taking into consideration not just short outcomes, but also long-term outcomes, and particularly if prolonging antibiotics and not having the daring to stop them may introduce harm to the patient, and we may use all of a sudden a biomarker to tell us, please, dare, stop antibiotics. And this is what we call the progress randomized controlled trial, where patients with sepsis due to upper urinary tract infection or community-acquired pneumonia, they are randomized to receive empirical standard of care antibiotics as long as the physicians they need this should be the case, or antibiotics which they stop when the rule of procalcitonin is met. That means at least 80% decrease of procalcitonin or procalcitonin less than 0.25. If this rule is not met on day 5, then there is a repeat of sampling on day 6, 7, or 8, and antibiotics stop when the rule is met. We are interested about the follow-up of day 25, but the primary endpoint is what happens to the patient after 6 entire months. And in parallel, we collected stool samples to test and to screen for antimicrobial resistance. And we elaborated a composite endpoint. The composite endpoint for the progress trial takes into consideration over time how many of the patients will develop what we call infection-associated adverse events. That means any infection by Clostridioides difficile, which is impacted by long-term treatment of antibiotics. Any infection by multi-drug resistant organisms, which, as we have seen, their incidence is impacted by long-term treatment with antibiotics, or death by the infection for which they were enrolled in the trial. And as you see, that was extremely successful. The primary endpoint was met in more than 50% of patients receiving standard of care duration of treatment, and it was reduced in half in patients stopping early antibiotics using the procalcitonin rule. Someone may say, okay, can you prove us now that this has to do with fecal colonization? And here you see the odds to develop these long-term complications. If you are colonized by resistant bacteria and you are in the standard of care long treatment in blue, and how this is statistically going down if you are in the intervention arm, and this statistical difference is taking place both on day 7 and day 28. In other terms, the protection from long-term effects is associated with the prevention of development of resistance in the gut. And the key primary endpoint of the trial was mortality. And we were struck by surprise by finding that by day 28, the death rate was 28.2% in the standard of care arm, compared to 15.2% in the procalcitonin arm, and 50% of the patients were protected from death. And then someone may say, now it becomes serious. Can you show us the mechanism of protection from death? As you may see in our curves, there is no doubt if you use procalcitonin, the exposure to antibiotics is shortened. But long-term exposure to antibiotics means long-term adverse events. And these events are antibiotic-associated diarrhea. They are acute kidney injury or adverse events having to do with electrolyte disturbances. And if a patient is labile and is septic, if you prolong antibiotic treatment, then you make him much more prone to these adverse events, and this undoubtedly affects survival. With this in mind, I would like to finish my talk with some considerations. In patients with mild lung infection, we need to start antibiotics when PCT is more than 0.25. We should stop antibiotics using an approach and an attitude to have at least 2 PCT measurements, one before start of antibiotics, a repeat measurement after the first 5 days, and decide to stop antibiotics when we come across a decrease of at least 80% compared to baseline or when PCT is less than 0.25. Because with that approach, based on the results of the PROGRESS trial, the strategy provides protection to the host for 6 entire months from infection-associated adverse events, by reducing the incidence of stool colonization by multidrug-resistant bacteria and Clostridioides difficile, by reducing 20-day mortality through the reduction of antibiotic-associated adverse events, and also this reduce of the time to stop of antibiotics in our publication is associated with a decrease of the cost of hospitalization and in the decrease of the length of hospital stay. I would like to thank you very much, and I'm looking forward to this discussion.
Thank you very much, Professor Giamarellos, for your very interesting presentation. It was very clear to me. It's from the perspective of the clinicians. I'm a laboratory man. Therefore, it was really, really great to hear you. And I think you give some aspects how to use PCT really in practice, not only to order it, but to use it. Thank you very much. Now we are at the last part of this webinar. Are there any questions? I only see one question at the moment. That's how is PCT kinetics affected by CRRT? I don't know what the acronym CRRT mean.
Oh, yes. So my understanding is that this comment is coming from someone who's from the intensive care world, and they are implying the continuous hemofiltration. In other terms, whether procalcitonin kinetics may be impacted by renal failure.
Okay.
To be honest, daily in clinical practice, I am coming across this challenge by my fellows, by my residents, that all these propeptides, when a patient is suffering from acute kidney injury, may be impacted by either hemofiltration or acute kidney dysfunction. I have done a long search in the literature to see if this is the case. Honestly speaking, I did not find something supporting that, and also our results also do not support that. And really do believe that this is nothing more than a conviction which is coming from other peptides like troponin, which indeed are impacted by that process.
Yeah.
But when it comes to procalcitonin, you need to stay confident. The rule applies in all cases.
Okay, it's not affected in
It's
a
not
few
affected.
words. Okay, thank you. There's a second question. Does PCT monitoring have any benefit for nursing home patients? There are outpatients in homes of elderly people, in Do you have any
Well,
experience?
this is a very interesting question. I have not seen any publication on that. All I know is that patients who are staying long-term in long-term care facilities, they behave in terms of procalcitonin similar to the rest. There is no doubt that not all of us are able to produce the same amount of procalcitonin. Some of us, we can produce more, some less. The way procalcitonin is produced, and you mentioned that already, it was mentioned in the previous talk, is that each of our small cells produce a very small amount and this sum up. This is why, for exactly the same time of infection, even for patients who are in need of the same quantity of vasopressors, one may have a procalcitonin of 100 and the patient next to him a procalcitonin of 2. So the idea of the algorithm of stopping antibiotics is not to give you absolute numbers. If procalcitonin at baseline is extremely high, then stop antibiotics if this goes down by at least 80%. For instance, if a patient has a baseline of 100 and it goes down to 19, don't be afraid because it went down to 19. The gap which is between the 100 and the 19 for that specific patient is huge. He's doing better, and don't be afraid to stop antibiotics. However, if you have a patient who produces tiny amounts and he starts treatment with a PCT of 0.7 or 0.8 or 1, once he's down to 0.5, then you may be safe that after 5 days with a PCT less than 0.5, you may stop antibiotics. And this applies for all patients, irrespective comorbidities and background.
May I ask a question? What are with false positive or false negatives PCTs? Are this a critical case in the clinics?
Well, thank you very much for that, and this is very important. You have seen, and that was the message I want to convey in my case of the patient who I presented being improved hemodynamically. And then I said, as I asked our audience to feedback their opinion on the patient, that look, the patient is stable and procalcitonin is decreased. So as a matter of fact, what is important is to be certain that the patient is doing better, he's stable. And the question if the patient is turning better is that now that he's turning better, may I stop treatment? In that case, undoubtedly, procalcitonin may help you. So with that approach, we are not risking any patient for false positive or for negative results.
Okay. I see no more questions from the audience. Therefore, I thank all of you for listening to us and be part of the webinar. And to finish, I will bring back the closure to Christy from LabRoots. Christy, please, it's yours.
Thank you, Professor Baum, and thank you to Professor Giamarello and Professor Gruson for their presentations. Such valuable information they provided on how procalcitonin improves patient outcomes, contributing to antibiotic stewardship efforts. As always, it's a privilege to host webinars with you all here at Thermo Fisher Scientific. Now, before I go, I do want to thank our audience for joining us today and for their interesting questions. Questions that come in during the on-demand period, they will be addressed by our speakers via the email address you provided at the time of registration. Today's webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. You to share that email with your colleagues who may have missed today's live event. And I do want to make a note that procalcitonin.com is a website that you can go to. Again, that's procalcitonin.com. Thank you again for joining us, everyone. Until next time, take care. Bye-bye.